Hello and welcome. I'm Devon Berrier, the Chief of Staff here at PAC. Welcome to the 2026 New Laws webinar. Today I'm joined by Cole Hoyt and Robert Miller from Hooper, Lundy, and Bookman. They'll walk us through important new laws taking effect in 2026 that will affect private practice physicians. Cole and Robert, thank you so much for joining us. I'll leave it to you.
Great. Thanks so much, Devon. Good afternoon. It's good to be back here again. You may recall Cole and I presented to you last year with an update for 2025. Just by quick recap, I'm Robert Miller. I'm one of the co-chairs of Hooper, Lundy, and Bookman's business department, physically located down here in LA. My colleague, Cole Hoyt, is also here in Los Angeles. He's in our litigation department. And we've been working together with Devon and Matt and the PAC team to identify what are some new laws that might interest you and that might be of relevance to your practice as a physician and to your medical group. So among the items that we're going to cover, there's a lot of new laws here. We're going to touch on AI. We're going to touch on some new reporting requirements that relate to healthcare transactions. And that includes not just like a sale transaction, but also transactions with management services organizations. And that's a little bit broader than what you might be thinking of a turnkey management services agreement. We're also going to talk about some laws that are impacting your day-to-day work in treating patients, including affordable insulin access, including new limitations around California's ban on the corporate practice of medicine and what that means for you as a physician, increased fertility coverage, prior authorization issues, vaccine access, then expansion to physician assistant supervision requirements, and more. And so at the end of this deck, we also want to touch on some labor and employment type issues. So while Cole and I and our firm, we are a health law boutique, first and foremost. We focus on health law issues. We work with a wide variety of physicians and medical groups on all kinds of issues. And we know from experience that the labor and employment piece is also important to you. That would be, for example, wage and hour claims, rules around what you can and cannot include in your employment contracts, and then again, some regulatory and reporting requirements that would apply more broadly, not just in the healthcare context, but to all California employers. We'll cover that at the end. And then, of course, we'll have the slides that are available to you. And then we want to cover some of PAC's priorities as well and things that PAC is looking forward to in the 2026 year and advocating on your behalf in Sacramento and beyond. So as you're hearing about all of these new laws, keep in mind these questions. So the first and foremost is, when does the law take effect? You may already know that in the absence of a specific provision, a new law takes effect at the beginning of the next calendar year. So that means that a law that was enacted in the last legislative session, signed by the governor at the end of 2025, that law would take effect as of January 1st of this year, meaning it's been in effect for about 6 weeks now. Some laws, however, have delayed implementation dates or even phased implementation dates. So, for example, it wouldn't be uncommon or unheard of for a law to take effect as of January 1, 2026, but then have a, say, July 1st, 2026 date by which you must implement some of the requirements, and then maybe even a later date. We've seen dates including some of these laws that are as far out as January 1 of 2028. So again, the legislature is thinking about, when does that law take effect? And consequently, you as a physician and a practitioner should be thinking about, when do I need to have made changes necessary to comply? Sometimes these laws change over time. We had just talked about how you have phased implementation of some of these laws. Other laws sometimes sunset. So you hear about a sunset provision, means that perhaps the law goes into effect on January 1, but absent additional action from the government, that law is going to sunset or expire in, say, 1 or 2 years. That's particularly true around technology issues. So a lot of technology issues. The theory behind the sunset provision is that it will cause the government to come back and rethink how has that law been implemented over the last year, 2, or 3, and then weigh in from a policy perspective on the future at that point. Another item to keep in mind when you're thinking about whether these new laws apply is the size of your practice. So the practice size does matter. It matters for a number of reasons. Just by way of example, we're going to talk about California's Office of Healthcare Affordability reporting requirements and recent changes under Assembly Bill 1415 or AB 1415. The definitions under that bill defines provider. That's a very specific defined term that includes a list of other organizations. One of those sub-defined terms is physician organization. It seems obvious. If you have a physician, you're a physician organization. But even that is specifically defined as a practice that has 25 or more physicians. And so something to keep in mind is just because a new law is presented on here today, just because you think it might impact your practice, that it would be prudent to go in and really dig into that law and dig into the defined terms that are used in that law to determine, is this really something that I need to be worried about as I'm planning for my business and my future? When we think about who's enforcing the law, it's a variety of regulators. One that I've already mentioned is the Office of Healthcare Affordability. We also have the California Attorney General. We have the Department of Consumer Affairs. We have, of course, the California Medical Board. So there's a wide variety of regulators who are really interested in care delivery and how physicians are practicing medicine in California. I would encourage you to think about, who is it that is likely to be most interested in this conduct? Is that because it's for example, a professional judgment issue, in which case that would be like the California Medical Board? Or does this touch on consumer protection? Perhaps it's an issue about the relationship between payers and providers, in which case maybe it's the Department of Consumer Affairs. Or do we think that the rights of Californians, for example, are being harmed? And maybe then it's the California Attorney General. But we're here to help you sort through that question and more. And that's a good segue into how can you stay current. I think that the best way to stay current is for you to remain in touch with PAC, remain involved with your organization, and bring questions that you might have to Devon or Matt or the team over there. Lawyers are also a great way of staying current. We have a number of client alerts on our website addressing these new laws. For example, I know that the AB 1415 update and a later one that we'll talk about, Senate Bill 351, SB 351. We have extensive reporting on those two bills on our website. Usually a quick Google search, if you type in a bill number, will get you the bill text itself. And if you click over to news or you look for links or you add law firm, you'll see a lot of content out there. And it's possible to get a general overview of what's going on through those articles. And then, of course, if you have questions that are specific to your needs or your practice, then we would encourage you to reach out to your lawyer, whether that's us or someone else. The most important thing is that you're getting the advice that you need to run your practice and focus on delivery of patient care. So let's go ahead and jump into some of these laws. The first one that we have up touches on AI. And with that, Cole, let me hand it over to you to talk about AB 489.
Thanks, Robin. And it's such a pleasure to be here. Before we jump in, just by way of background, I think Rob's last point is critically important in staying current, particularly as it relates to independent physicians or small practice groups. And by way of background, my wife's a physician, my brother-in-law is a physician, my mother-in-law is a physician, my father-in-law is a physician. And when we gather around the dinner table, the last thing they want to talk about is kind of new laws affecting them. And the majority of the conversation centers around patient care, right? How exhausting clinic could be, messaging patients back in the portal. But I promise you, the new laws, again, particularly to this group, are just so important. And again, taking a step back, physicians today, especially in California, are facing what many would think is an uphill battle. And we see the rise of labor costs, we see the rise of rent, we see more regulations, as you'll learn about later today. And all at the same time, the reimbursement rates from both Medicare, Medi-Cal, and health plans are relatively flat. And so with all that, as we'll get into right now, we're kind of seeing also this creep of AI into practice. And what California is doing with AB 489 is really prohibiting AI or generative AI from misrepresenting themselves as physicians. And the overarching theme and goal of this law is to ensure that when patients are interacting with an AI chatbot, that they understand that that is not a physician on the other end. And kind of historically, the California Medical Board and California Legislature has really made it a point to ensure that there is no unauthorized practice of medicine, and AB 489 is kind of the next step with the introduction of AI. If you recall from our presentation last year, there was another law mandating that anytime AI is used in communicating with patients, that it be reviewed either by a physician or lets the patient know that this was generated by AI, and AB 489 is just an extension. As I anticipate, and the new health laws of 2027 will likely see a new AI bill, and that will kind of continue. But again, just focused on AB 489. It prohibits AI and Gen AI or generative AI systems from representing themselves as licensed or certified healthcare professionals and physicians. And so where we might often see this is in a chatbot context. For example, whether it's kind of the ChatGPTs, kind of the big players, or even as simple as like a chatbot on your practice's website asking, trying to interact with patients. And interestingly, it gives enforcement authority to the state licensing boards and regulators. And so we think that this is going to be a really big area for state licensing boards to go after. And again, the main crux behind this is to safeguard really the trust inherent in the doctor-patient relationship. And as there's this developing trust between a patient and AI chatbot that I'm sure many of us have experienced, it's important to let the patient know who is a doctor and who is not. So again, if your practice utilizes AI chatbots or some sort of diagnostic tool, this is a really important law to take note of, and especially when working with vendors. Ultimately, it is also your responsibility as a physician, and especially as an owner of your practice, to ensure that the vendors are also made aware of the new laws and take it seriously.
Thanks, Cole. I want to repeat that last point that Cole said, because it is so important. And if I had a nickel for every time a physician client said to me, well, this vendor says that it's okay, or that they're doing this with a dozen other practices, and so why can't I wouldn't be practicing law anymore, I'd be retired. And the issue is exactly what Cole had stated. Ultimately, as a physician, it's your license that is on the line. And we think about patient care issues, whether it's good policy, we could debate, but right now the state of the law is such that it really is on you as the physician to be wary of vendor conduct that you feel pushes the limits, and in particular around the use of technology in your practice. And so I just want to flag for you, that doesn't mean that vendors are bad people or that they're trying to violate the law. It's just that the risk really is on the physician who's contracting with those tools to ensure that the vendor is not causing that physician to run afoul of his professional duties. Moving on to a little bit different topic here. So I touched before on Assembly Bill 1415. If you've been following along for years now, you may recall, I believe it was back in 2023, the halcyon days, that we had a new reporting regime created in California under the Office of Healthcare Affordability. Now, when OCA was created several years ago, it had two primary aims. One was to establish cost and market data. And so OCA plays a very important role in reimbursement and in setting reimbursement in the state. It also was charged with collecting data related to healthcare transactions and in particular, consolidation in the healthcare space. As you know, as independent practitioners and generally smaller medical groups, there's a lot of pressure around consolidation of physicians and medical groups. OCA started collecting that data several years ago, but the definitions implementing the law were not quite as tight as what the regulators originally thought. That is, there were some provisions that OCA viewed as loopholes that would allow physicians and other types of providers to make an end run around those reporting obligations and OCA. OCA and the legislature since went back to tighten those definitions. And here the important feature is that the definition of noticing entity, and again, that's a defined term, includes now newly created entities. And it also includes certain management services organizations. And so as of about 6 weeks ago, January 1st of this year, those reporting requirements were expanded to encompass a whole host of entities that 6 months ago would not have had to report their transaction to OCA. OCA is still in the process of implementing regulations to provide additional color and context into how it views that statutory authority. That's something that we're watching very closely as a firm. I would encourage you to sign up for client alerts if you anticipate that you might have a transaction involving your practice at any point in, say, the next year or two. I think it'll be really important. The direct and practical advice and the takeaway that I would hope you have from this particular slide and this new law is, if you are a physician practice and you anticipate entering into any kind of a business combination transaction, so that could be a sale of your assets, it could be bringing in new physicians, it could be merging with another group, or if you anticipate entering into a transaction with a management services organization, and that could be very broad, almost anyone who provides administrative or support services to your practice, then I would encourage you to check with your legal counsel and to confirm whether any notice filing is required with OCA. And so the penalties under OCA, or the penalties themselves, the main thing to keep in mind is the time frame. And so if an OCA notice is required, it's generally 90 days after the transaction is signed. And so think of it, or most physicians who I work with tell me they think of it as it's an additional 90-day timeline after their transaction in their view is closed, during which you're waiting just for that regulatory approval. And so again, as long as you're planning around it and you're structuring for that, that doesn't have to be a significant delay or gating item, but it's something that you would want to look into early if you anticipate that you have a transaction that might implicate OCA on the horizon.
Thanks, Rob. So next, this is actually what I think is a pretty breakthrough new law in California related to insulin access. So SB 40, which is now in effect, effectively caps the co-payment or patient responsibility for insulin access. And as physicians, you know, particularly with diabetes, how important insulin is. And so it really caps the price about $35 for a 30-day supply. And by context, that number just a few years ago was over $300 for a 30-day supply. And what is also interesting is there's no real requirements associated with that cap, i.e., regardless of income, those cost sharing limits are applicable. Now, what's really interesting to me, which is kind of the quiet part of the bill, is that CalRx, which is a program, a public-private partnership between California and some of the manufacturers. Their goal is to develop, produce, distribute a host of generic drugs, and the insulin access was kind of their hallmark effort and their first effort in this regard. And what I take this law to mean is that the state of California is taking CalRx seriously, and that this is kind of the pilot project to plan out how CalRx will attack additional cost savings for Californians as it relates to co-payments. I just read a recent report that albuterol and other medications are slowly going to be joining the program. Again, to be clear, not related to SB 40, but again, I think that this is an indication of what's to come in California. So again, starting January 1, insulin access is capped. The co-payment is capped, and this should be a big win for patients and those who use insulin in California. Interestingly, this was the 29th state to cap the cost of insulin. And as we've seen both in the AI bill previously mentioned and some others, because there is no federal law kind of controlling some of these issues, California has stepped in and really taken it upon themselves to do so.
Thanks, Cole. Again, just one note, Cole keeps ending his slides with really interesting comments. And so we're talking about in the absence of federal law, the 50 states are left to decide what's best in their state. That's federalism, and that's our core constitutional system. One of the things that might be interesting if you follow politics as closely as I know the PAC team does and we do, is that there's pressure in Washington, D.C. to act. In particular around AI and regulation or lack of regulation, as the case may be. But there's particular pressure around those who are close to the current administration for the federal government to act by preventing the states from acting to restrict how AI is used. So it's a little bit of an interesting argument, but something to keep in mind over the next year and to keep tabs on is there anything happening in Washington that might preempt state action on regulating AI? And if not next year, is that coming in the future? AI is still very new, but its popularity has exploded. Virtually everyone has interacted with AI in some form or fashion. So I think that that'll be an interesting area to watch over the coming years, and one on which I'd encourage you to reach out to your PAC team for updates. Moving on to Senate Bill 351, SB 351. This is, at least for me in my practice, this is most physicians' favorite topic. It's California's ban on the corporate practice of medicine, and really diving into what does that mean, how is that implemented, and what are the changes that we should expect to see. So SB 351 does a number of things. And so it specifically targets private equity and hedge funds. And now both of those are defined terms, but in some cases they're defined so broadly that it's unclear whether, for example, if Cole and I each kicked in $100, if that now makes us a private equity firm for the purpose of investing in a physician practice. So it could be a very broad definition. And it says that those groups will not affect the clinical decision-making of physicians in exercising their professional judgment. Now that sounds good, and you've probably heard over the years that that is in fact true. And the interesting thing about SB 351 is it appears to take existing guidance from the California Medical Board that has been around since 1999 or 2000, and it has codified that guidance now as a statute. And so before there was this statutory framework, the guidance from the California Medical Board was persuasive, but it was not binding. It was not the law. Now that that guidance has been codified, there's a California statute on the books in the Business and Professions Code that is updated by this SB 351 that enshrines the ideas from that 30-year-old or 25-year-old medical board guidance that says, for example, that physicians shall be in sole control of making any diagnosis and treatment. Physicians will be in charge of determining which codes to bill in billing and collecting, that physicians will own the patient records of the practice, that physicians will determine reimbursement rates, how many patients are seen in a day, will control payer-provider contract negotiations. So in our view, 351 doesn't so much expand the corporate practice of medicine or expand the conduct, but rather it codifies conduct that already was viewed by the California Medical Board as conduct that was that would be violative of California's ban on the corporate practice of medicine were a lay entity to engage in it. As we've said here, it applies to physicians and dental practices. That's true for the California ban on the corporate practice of medicine in general. One unique wrinkle that SB 351 pulls in that is a change in the law is that it limits a management services organization, that entity's ability to enforce a non-competition covenant or a non-disparagement clause in a provision with a provider after the provider resigns or leaves that PE-backed practice. So one of the things that we're watching with some curiosity is the bill says this prohibits non-competition covenants and non-disparagement clauses in a particular situation. And then in the very next subparagraph, it says, this doesn't do anything to affect otherwise enforceable non-competes upon the sale of a business. And so we're getting into a very facts and circumstances specific issue. But if you have a non-competition covenant or a non-disparagement clause in your existing agreements, or if you're asked to enter into agreements that contemplate restrictive covenants along those lines, that would be an excellent time for you to engage counsel to review those documents, and in particular to help parse, so which is it under SB 351? Does this look like an enforceable restrictive covenant? Or does it look like it's not an enforceable restrictive covenant because of this change in law? Overall, SB 351, I think, is also a trend line in California and both nationally, showing that there's a lot of interest in state houses across the country in really understanding and reining in the influence of profit motive in healthcare, and in particular, lay entities that get into the provision of healthcare services driven by that profit motive. So think hedge funds and private equity funds. Sacramento and the legislature has looked at bills like this for at least the last 3 years. SB 351 passed this year. It did not pass in prior years when they made some tweaks to that language. But in general, I would expect that many state houses across the country will continue to heavily scrutinize investment in healthcare, and in particular, private equity and hedge fund investment in physician practices.
So SB 729, I'm particularly interested in. My wife's an OBGYN, and there's been countless examples of some of her patients not being able to afford fertility and IVF coverage. And so this is, I think, kind of a really historic law in California and really leading the nation about what it does. So as there's a few caveats that are very important. So SB 729 for now requires large group health plans, which is typically more than 100 employees for the covered plan, to cover IVF and fertility preservation. Importantly, it includes the diagnosis and treatment for infertility, and it eliminates any exclusions affecting same-sex couples and single individuals. The law started January 1st of 2026, but again, another important caveat being that it really starts when the insurance coverage renews. So if it renewed on January 1st, starting new coverage of 2026, the law's in effect. But many health plans don't renew until, for example, July 1 of 2026, and it's after that period that the law would effectively kick in. So let's talk now about what it covers. It covers infertility diagnosis and treatment, IVF, with some restrictions, and then medically necessary fertility preservation. So think about freezing. But again, another important caveat is that it has to be medically necessary. So this would often be for those who are undergoing cancer treatment in order to preserve their eggs. Likewise, it covers related services, so fertility medications, monitoring, lab work, and standard treatments. And again, it doesn't single out who the patient needs to be. So it could be, those in same-sex relationships and other individuals, even those who are single. So again, this is a really important historic law. If I'm thinking critically, I'm going to be interested to see what REI doctors do with this new law. Historically, as many know, reproductive endocrinology and fertility are usually cash pay. And I'm very interested to see how many REI specialists start accepting insurance and go through that headache or remain cash pay. Again, if I'm also thinking about the future, what we often see in laws, and again, we've seen it in AI and a number of other fields, is the legislature will kind of introduce the first law and then follow up in relatively rapid succession in the coming years to either expand access or kind of refine what the law is. And so I, again, predict in the coming years that California will double down on this initiative and make it a requirement across different health plans. So those covered, for example, by Medi-Cal or Medicare Advantage lines. So that is something to be seen, but I think that this is a strong step in the right direction. And I'm, again, very optimistic and hopeful that this expansion will only continue to grow. Next, also, I know near and dear to a number of physicians is prior authorization, transparency, and reform. This is through Senate Bill 306. I'm going to start by why this is important, and I can't see any of the audience, but I know a lot of you are shaking your head. Prior authorization is kind of one of the biggest pains for practice groups, particularly if you're an independent physician or in a small practice group, because it takes so much time. You have to see the patient. Oftentimes there's lab work involved, and then it's always a back and forth experience with health plans to get the prior authorizations approved. 25% of physicians report that prior authorization has led to a serious adverse outcome event. And a physician, according to a national study, does about 43 different prior authorizations per week. Patients, importantly, about 85% experience treatment delays. And as you know, there's huge increase in administrative burnout. There's additional administrative costs. Oftentimes physicians are paying a person and or a group solely to deal with the prior authorizations. And this law is intended to kind of help ease that burden. So now let's talk about what the law is. It simply requires health plans regulated by the state of California, so either through the California Department of Insurance or through the Department of Healthcare Services, to report prior authorization data used to regulators before the end of this year. And so what we expect is that the big health plans will use their likely AI to go through and see what were the biggest prior authorization in terms of how many prior authorizations, and out of those, what percentage of the time was a prior authorization approved. And so the data is supposed to track approval rates, denials, and processing timelines. And ideally, it will allow DMHC, the Department of Managed Healthcare, and CDI, the California Department of Insurance, to identify by July of next year which services were approved about 90% of the time. And with that, starting in January 1st of 2028, the intention of the law is for health plans to stop requiring prior authorization for those services that are approved about 90% of the time. Again, there's some caveats. If a health plan believes that a provider is engaging in fraud or there's some suspicious activity, they might still be able to require prior authorizations. To be fair, there's a little bit of smoke and mirror with this law for a few reasons. One, because the timeline extends out so far. And two, we anticipate some follow-up legislation to perhaps refine this law further. What it means practically, as you know, oftentimes currently prior authorizations require a inpatient visit or sometimes a remote visit. And even if the prior authorizations still go away, I think it would be appropriate based on your clinical judgment to still see patients to ensure that the medication that the patient is on is still in their best interest. So again, in sum, my interpretation analysis is this law really is intended to help physicians take away the burden that is obvious, and two, to get patients their medication without unnecessary delay and burdens. Kind of keeping thematically in the line of providing better care to Californians and to kind of ease some of the pressure that physicians are facing. AB 144 allows and requires vaccine access and coverage protections for Californians if the health plan is regulated by California. So again, CDI or DMHC. And importantly, it requires health plans to cover vaccine access and administration pursuant to the California Department of Public Health's updated guidance. And as Rob had mentioned earlier in the presentation, there's often, regardless of administration, a push and pull between the federal law and the state law. And I think this is just an example of the state law fighting back against recent developments on the federal side. And so, again, the result of AB 144, it requires health plans regulated in California to cover immunizations recommended by the California Department of Public Health. And importantly, CDPH has developed their own guidelines, in essence, modifying in part the federal guidelines based on scientific information, such as from ACOG and other organizations. And again, I think this is a continued step by the legislature to provide quality, important care and access to Californians as the year progresses.
Thanks so much, Cole. So our last substantive slide here, and I say that because we'd love if you would share your questions with us. Cole and I wanted to make sure that we reserve some time at the end to handle any questions that come through. And as a reminder, we're also going to chat about those recent changes to labor and employment laws, updates around wages, hours, and then some items that you should consider when you're contracting with physicians and other providers in your group. But here, Assembly Bill 1501 is a reaction by the legislature to physicians' assistants looking to expand their scope of practice and the legislature's public policy interest in ensuring that more Californians receive the care that they need. And physicians, are stretched thin. And in many areas of the state, in particular underserved communities, physician's assistants bridge that important gap where physicians are unable to see the volume of patients that need additional care. And so in recognition of those efforts, plus the physician's assistants lobbying for additional authority, there's a new bill, this AB 1501, that really expands the framework and updates the framework that governs physician's assistants. It modernizes the board governing physician assistants. It updates license fees and application process, and really brings new structure and formality to the regulatory side of being a PA. And then it also is designed to improve patient access. And one of the key ways that they've done that is by expanding the supervision ratio from 1 to 4, as you may know, with some limited exceptions, to a general rule of 1 to 8. So that is to say, the biggest change to keep in mind is that a physician now may supervise up to 8 PAs. So double the number of PAs that a physician could supervise before this new law took effect. In your practice, things to keep in mind are, how does this comport with your existing arrangements? What about your current supervision structures? Is there perhaps an opportunity for you and your practice to take advantage of changes in AB 1501 to supervise more physician's assistants, or to bring more PAs under the umbrella of an existing physician who maybe has more experience supervising or is otherwise better positioned to take on that supervisory role? Your practice agreements, both with PAs and with supervisory physicians, is now a good time to revisit those to better capture the relationship between those parties, and then also to make sure that it accurately reflects what's happening, that level of supervision, that you're maintaining those ratios in your practice and ensuring that you're complying with the law. And then lastly, a very practical note here, don't forget about your insurance coverage, and make sure that your insurance coverage accurately reflects how your practice is organized. So for example, if you decide to have a physician expand her supervisory role to 8 PAs, make sure that your insurance coverage allows for that and that you're covered. And that would be usually just a quick call to your broker to make sure that that is in place. All right, I'll leave this presenter slide up for just a moment. I want to tick through some labor and employment issues, and then I see that we have some questions as well from the audience. So Cole, if you wouldn't mind, if you could take a quick look at some of those questions that are rolling in. And I'm going to run through this list. We'll call it a lightning round of new 2026 labor and employment laws. So the first one that I wanted to touch on is the new statewide minimum wage. Now, I understand that depending on where you're sitting right now, you may be shrugging your shoulders and thinking California's new statewide minimum wage rising to $16.90 per hour, and then for full-time exempt employees going to just north of $70,000 doesn't impact me because I'm in a jurisdiction that already has a higher minimum annual wage. But I would encourage you to still keep that in mind, especially if your practice looks to expand. There's also additional rules that apply to certain fast food workers that you may have seen reported in the news, where there's a $20 per hour minimum wage. More relevant to you and your practice, certain healthcare workers are also subject to higher industry-specific minimum wage rates. And again, those also impact the minimum exempt salary calculations. And so we just wanted to flag for you to be sure to stay on top of not just the state level, but also the local level minimum wage and minimum exempt salary requirements, as those are currently going up in many places. And just want to make sure that you're keeping that in mind as you're planning for your business and also staying abreast of wage and hour requirements. We have a new bill, SB 642. that expands transparency, pay equity enforcement, and reporting obligations. The idea behind this bill is to gather more information about discrimination in pay. It also expands compensation and extends the statute of limitations for Equal Pay Act claims from 2 to 3 years, and it allows for recovery of damages going back for 6 years. So taken together, what this does is it expands the reporting requirements, and it also empowers plaintiffs to have more time to review the data, and if there is a recovery, to go back further in time, expanding overall that potential recovery. And so we would encourage you to check with your regular labor and employment or L&E counsel. If you use an ADP or another payroll solutions provider, this would be something else to make sure that they're paying attention to these changes and that they're complying with any reporting requirements on your behalf. Another new bill, Assembly Bill 406, governs leaves of absence. And so it expands authority for employees and qualifying family members to take time off to attend judicial proceedings, and also expands the permissible uses of sick leave to include certain judicial proceedings, jury duty, and witness leave. I suspect that this will affect you most directly through updated model notices from enforcement agencies. Again, if you use, for example, like an ADP or a back office payroll or HR provider, this would be another bill where you might want to check in with them to make sure that you are covered. Similarly, Senate Bill 590, SB 590, expands California's paid family leave program to allow employees to receive benefits when caring for a designated person with a family-like relationship. Although this is a good example of a law that passed in January or in the last year, was signed into law, but this change does not take effect until July 1 of 2028. So there is an implementation period here. One that I personally have been working on with clients, and that is very important if you do any type of recruiting agreement, if you do any type of retention agreement, if you pay any type of bonus agreement in your practice, and any of those amounts are subject to repayment if a physician leaves the practice. And so a classic example would be you pay a bonus to recruit a physician to your practice or maybe your geographic area. And then that physician, if they leave after, say, 1 year of a 3-year deal, then some amount of that bonus is subject to a clawback or a repayment right. Then this bill affects you. This is Assembly Bill 692, and it sets out very specific parameters in which an employer may include repayment or clawback provisions in certain contracts after January 1 of 2026. So if you have agreements that predate January 1, 2026, my recommendation would be that you have your legal counsel review them to confirm that they're still applicable and enforceable. If you enter into any new contracts that include that type of repayment or clawback provision after January 1, so within the last 6 weeks or hereafter, then you should have your legal counsel review them to make sure that all of the statutory requirements imposed by AB 692 are met. And so there are stiff penalties for employers who do not comply and who try to collect amounts from employees in violation of the statute. And there's only limited exceptions in which you can require repayment. Some of those include government loans, qualifying tuition repayment or apprenticeships, certain signing bonuses, or other similar types of compensation. So again, if you have agreements where you have a repayment obligation with an employee after they leave for a certain period of time, I'd recommend that you have legal counsel review those arrangements. SB Senate Bill 294 addresses notice and record keeping requirements on employers. This is, again, something that ADP or an HR provider likely handles on your behalf. But nonetheless, employers must distribute an annual notice discussing workers' compensation, immigration protection, concerted activity rights, and constitutional protections when interacting with law enforcement beginning this year. You have to record compliance with those notice requirements for 3 years. And the law requires that employers allow employees to designate an emergency contact and to notify that employee, that designated contact if the employee is arrested or detained at the work site. Wage and hour enforcement under Senate Bill 261. Enforcement authority and penalties are increased under several new laws. So any delay in satisfying a final wage judgment beyond 180 days could now bring liability, including potential treble damages, attorney's fees, and enforcement by public prosecutors. And so the policy here, the legislature is very concerned with making sure that those final wage payments are paid in a timely manner. And they're creating additional risk if you do not do that. And so again, if you have wage and hour issues, now would be a good time to discuss with your counsel, discuss with your payroll provider or your HR team, how are you ensuring that you're complying with these new updates from a labor and employment perspective. So Cole, I know that we've had a few questions roll in. I'm going to turn it over to you. And I'm happy to expand the conversation. Perhaps we can take the slides down and put both Cole and I up. I know we have about 8 minutes left, excuse me, of everyone's time. I'm happy to do as much as we can to answer the questions online. And then if it looks like it's more complicated, if it relates to a particular situation, Cole and I are happy to take up the questions offline and respond to you. In that case, I hope that we have your contact. Perhaps someone on our presenting team can give me a note if we need to request that through some form or fashion. Cole, let me turn it back over to you.
Yeah, I'm gonna bat it right back with one question more in your wheelhouse, and then I'll finalize with one question on something that I think I could handle. So the question is, have rules changed on the documentation needed of annual review of collaborative practice agreements?
Yeah, I don't believe so. I don't think that there's been any particular change, at least to the documentation requirement yet. But that would be something to keep abreast of as the statute is implemented. And so just zooming out just a little bit, it's a great question. We've got a system in which the legislature meets, the legislature passes bills or statutes, those become the law. And oftentimes those statutes are relatively high level. And so the governor signs it into law, it becomes law, and then a regulatory body is charged with implementing the statute. And that regulatory body may promulgate regulations. That's the fancy lawyer term for they may look at the statute and then provide some additional language around here's what we, the regulatory body, think this statute means. And so off the top of my head, I don't recall any changes in documentation under AB 1501, but something to keep in mind is there could be subsequent regulations, either, for example, from the California Medical Board or from the board that governs PAs that really addresses that topic. I think it's a great question, and that's one that, so right now my answer is I don't think there's anything. But feel free to follow up with us or the PAC team in the future. I'm sure that that's something we'll be watching closely.
Thanks, Rob. And another question that I'll take is, does AB 1501 include supervision in an inpatient and outpatient setting? And what is the effective date? And is there a supervisory doctor still required to co-sign the notes and treatment plan by a physician assistant? So yes, it includes all practice areas. Just by way of context, the old law was a 1-to-4 physician to PA ratio in most settings, with an increased ratio of 1-to-8 for in-home health evaluations. The new law expands that to a 1-to-8 ratio across all practice settings statewide. The law is effective January 1st of this year, which is important since it is now in effect. And the final part of the question, whether a supervisory MD is still required to sign the note, our read is yes, that was not changed in AB 1501. It was just more so to expand the ratio requirements from traditionally what usually was 1-to-4 to now 1-to-8. I see a few other questions that might be better addressed that we could do offline, and we will reach out to you. Rob, in the next kind of 3 minutes, what are you looking forward to kind of for the rest of the year, and what do you think is going to happen kind of the start of next?
Yeah, thanks, Cole. We talked about that when we were prepping. I think that's always the most interesting part of these presentations, and we only have a few minutes to cover it. But I almost say battles, but that's not really the right term. But the arguments that I'm really interested in seeing play out over the next year relate to, one, the patchwork framework that we have for regulation of AI, not just in healthcare, but overall in the country. My prediction is that's going to be a front page news cycle issue at some point during the next 12 months. I think we'll see mainstream reporting across a wide variety of sources. And I hope that we do, because I hope that we have a full and free debate over what is it that we would like to see. I think that there's a lot of interest on the consumer side around AI in healthcare. I think physicians and those of us who are in the industry or who do a lot of work with physicians are maybe a little bit more skeptical about the role that AI is going to play, or about maybe some of the dangers associated with having an AI system that gets very close to diagnosis. And I'm really interested to see how that plays out. I think California will be very interested in watching that debate as well. The one that perhaps impacts me most directly in my practice really relates to the expansion of notice and reporting requirements for transactions. I mentioned earlier that it's a trend line. This is going back at least 5 or 6 years now. You may recall, if you watch other types of providers in this space, there was a large bankruptcy that played out in Massachusetts, the Steward Healthcare bankruptcy. And I think that that was a catalyst for action around private equity involvement in healthcare. And that's not to say that all private equity deals go as poorly as the Steward Healthcare deal, but I think that there was a lot of energy attached to seeing how that hospital and that system really falling apart in Massachusetts sparked a lot of interest in state houses about avoiding a similar scenario. When I think about California, we have a lot of challenges in funding healthcare. I think there's a tremendous amount of tension between unfunded mandates for physicians and other types of providers, and then making sure that there's reimbursement dollars available to pay the clinicians who are going to be providing care. I think we see that play out in a number of areas. One that is near and dear to me is I think about my background representing community hospitals and really championing healthcare in rural areas, is how can we maintain these community hospitals, and how can we maintain not just independent hospitals, but acute care hospitals in areas that are underserved, in particular in the wake of cuts from HR 1, sometimes called the One Big Beautiful Bill Act, where there's going to be a lot of money coming out of the Medicaid system. And that's going to impact and potentially impact significantly providers who are heavily dependent on Medicaid funding, whether that's physicians, hospitals, or otherwise. What about you, Cole?
I'm going to double down on that. I think the obvious answer is more regulation in AI. I think given the flat reimbursement rates and increased costs, AI will hopefully be a big cost saver and profit driver for physicians. And I think that that will only become more apparent through additional AI applications, not so much on the patient side, but more so on the provider and operational side. And I think that the legislature is going to be kind of a real follower of that and hopefully make and pass legislation helpful to providers. So one, we're going to continue to see an AI. This is our second year on AI, and I'm going to double down on my bet that AI will show up in one form or another next year. Two, I think what we've now kind of seen consistently, California really trying to provide additional access and benefits to their constituents and to the citizens in California. This year, we saw it through vaccine access, lower costs in insulin, and access to infertility. I think that's going to be the tip of the iceberg, and these are really kind of pilot programs that the state is going to monitor and double down. And I think, and I'm hoping that the legislature will continue to pass various laws to ease the administrative burden on physicians. Everyone wants a doctor to practice medicine, and they want to take all the non-practice of medicine aspect out of their day-to-day lives as much as possible. And I'm hopeful and slightly optimistic that the legislature will follow through on that. So we'll see you next year and see if these predictions held up. And again, we're out of time, but please feel free to reach out to Rob and I offline, and we're happy to answer any questions there.
Thank you all very much.
Perfect. Thank you so much. So long.